right, welcome everyone. Thanks so much for joining us. Today we have Dr. Botts to talk about telehealth during the coronavirus crisis. So today for the virtual meeting, if you attended our webinar last week, it's going to run very similarly. Everyone is muted. When you're as a participant, you can have chat function or ask questions via the Q&A function. It should be either at the top of your screen if you're in full screen or at the bottom of your screen if you are not in full screen. If you're on a phone, the best way to get to the chat is to click on participants and then chat. If you're on a computer, the chat bar and the Q&A bar should just be there for you.
Good morning. This is Jeff Towns, the Executive Director at the MOA, and I welcome all of our members to this special presentation by Dr. Eric Botts on billing, on telehealth and billing and coding principles around it. Dr. Botts is an OBC principal and owner, and also an MOA business partner, supporting our members in billing and coding questions throughout the year. So we don't want to waste any more time. We want to try to get right to it. So let's get things going this morning, and welcome Dr. Eric Botts.
Well, thank you. And I appreciate the opportunity to share some information with your members. And the one thing I'll also add to that introduction is I'm also a practicing optometrist, learning how to do this just as all of you are. These are obviously unprecedented times we're living in right now. And the one thing I can tell you is that things are changing. And everything I talk about today, I know to be true today, but I will say things could change. So be sure and stay tuned. If anything does change, I'll be sure to pass it on to the MOA so that they can share it with you as well. So this presentation is about telehealth and how it's impacting optometry. I'm going to have you change that slide for me. There we go. So first, just a brief explanation of what exactly is optometric telehealth. A lot of it depends on the state you practice in. Telehealth is not necessarily new, but it is new to a lot of optometrists because we really haven't practiced telehealth to any extent in the past. Other professions have, and Medicare actually has had a couple different codes available for telehealth for a little less than 2 years now, but we're just now getting into this primarily because we're being forced to because of the COVID-19 pandemic. But telehealth is basically patient care without face-to-face contact, without live contact between the doctor and patient. Go ahead and change slides, please. So how has it changed? Well, recently it's changed pretty significantly because the president and governors of I think all 50 states have basically said telehealth is available for every practitioner, for every healthcare provider to utilize at this time, whether they did before the crisis or not. You can utilize it now, get reimbursed by Medicare and most commercial insurances. And the reason they did this is because they want patients to be able to get care without necessarily putting themselves at risk to exposure to the coronavirus. One of the big changes here that really has opened this up is that HIPAA compliance has been relaxed a lot. And that's to allow us to do telehealth. The current use of cell phones to do telehealth exams probably is not going to meet the criteria for HIPAA compliance, and that's why the powers above have relaxed it so that we can do telehealth without having to worry about HIPAA compliance. Now, these changes may be temporary, so this is something to stay tuned to for for further updates. I'm going to change slide, please. So 2 codes that have been available for the last 18 months to 2 years. One is the virtual check-in code, the G2012. This is a code that reimburses a very low amount, about $15. This is really first designed for the doctor to be able to communicate with the patient and decide whether or not an exam, in-person exam, needs to be performed. So it's really just a brief communication utilizing a telephone or some kind of digital device to communicate with the patient. It cannot be part of a prior diagnosis or any diagnosis that was evaluated in an examination within the last 7 days. And it also can't lead to an evaluation within the next 24 hours. If that's the case, then you would not, if you do a virtual check-in with a patient and you decide that you need to see the patient within the next 24 hours, then the check-in is actually going to be part of the examination that you bill when you see the patient within the next 24 hours. Now this check-in can be performed via telephone or any kind of live video interaction, such as FaceTime or Messenger or Skype. Next slide, please. The other code that was brought forward about 18 months ago is the G2010. Reimburses approximately $12. And this is one that you may have been performing for quite some time now without necessarily billing for it or actually documented as an exam. This is when somebody sends you a picture of their red eye and asks you to look at it and give them recommendations on what to do. And I'm sure you've all had a family member or friend take a quick selfie of whatever eye issue they've got going on, send it to you and say, hey, what should I do about this? Well, if you've done that in the past and done it for free, I'm going to tell you that there is a code that you could use to get reimbursed, and that's the G2010. This is something that can be stored and then forwarded to you at a later time. So this is not necessarily a live connection with the patient. Typically, they'll send you a picture, and then within 24 hours, you will follow up with the patient and give them a diagnosis and recommendation. It cannot arise from a prior diagnosis that was evaluated within the last 7 days with this patient, and also cannot lead to an examination within the next 24 hours. If it does, then this remote evaluation is basically just part of the examination that you perform tomorrow. Next slide, please. So the other way that you can bill an examination, and this is where things have really opened up and changed because of the COVID-19 pandemic, is that you can now bill a 99 level office visit without actually seeing the patient. Now, you're going to bill it at the same reimbursement as you would if it was an in-office examination. And I think it's very important to note that the 92 codes are not billable as a telehealth examination. It's only the 99 codes that are going to be billable here for telehealth. You need to document for the telehealth exam the same as if it was an in-person exam. So you have to have a chief complaint, a history of present illness, a patient medical history, examination procedures or examination elements that you perform, and then a diagnosis and a plan and medical decision making. Those all have to be documented. And this has to be performed in real time using audio and video interaction. So it's going to be FaceTime or Skype or some means to be able to communicate directly with the patient in a live format. You have to be able to see them and hear them for this to be billable as a 99 level office visit. I think there's some limitations here. I don't think you're going to do 4 and 5 level exams as part of a telehealth examination. I think the 99202, the 99212, the 99203, and the 99213 are probably your most likely performed examinations. And a couple of notes here, and there has been some changes with this since this first came out, but you will be using the place of service as the 11, which is the same as if you were performing this exam in your office. And I would also recommend that you use a 95 modifier with the 99 code so that it is identified as a telehealth examination. Now, some of you may have seen, read, heard that when this first came out a couple weeks ago or 10 days or so ago, that they were recommending the O2 as place of service, which is telehealth designation. But I'm going to tell you right now that you want to use 11, and I think primarily that is because most insurances were not set up to allow us to do the telehealth with the O2 modifier, and so the claims were getting denied. So I would recommend to you, if you submitted any claims with an O2 place of service and they get denied, I would immediately resubmit them with 11 place of service. Next slide, please. So another option for you is an online digital evaluation. And these codes, the 99421, 422, and 423, these are actually designed for telehealth examinations, okay? They reimburse between $17 and $54 depending on whether you're doing the 99421 reimburses around $17, the 99423 reimburses around $54. This is communicating with a patient via a secure patient portal. It does not have to be live, but it can be. Some of you may have an EHR that allows you to communicate with your patient via a secure patient portal. There's also portals out there like MyChart that will allow you to do this. Now, I don't know how many of us actually have this set up in their office, so I don't know that many of us will be doing the 99421, 422, and 423 examinations. But this is definitely another option for you for new or established patients. Like I said, it doesn't have to be live. Information can be stored and forwarded to the doctor at a later date. It like the other codes that we talked about, it cannot arise from a prior diagnosis that was evaluated in the last 7 days, and it can't lead to an examination within the next 24 hours. If any communication that you have via telehealth with a patient does lead to an exam within the next 24 hours, then you're just going to bill the one office visit with that patient. You won't be billing a telehealth in addition to a live examination. Now, the way you break down the 9942 codes is the first one, the 99421, is basically 5 to 10 minutes spent communicating with the patient or evaluating the information with the patient and then getting back to them and communicating your findings. If you're spending 11 to 20 minutes, then you're going to bill a 99422. And if you spend more than 21 minutes, it's going to be a 99423. So these are all time-based examinations that are telehealth examinations. And it's important to note that it doesn't have to occur all at once. You could be communicating with this patient potentially over a 7-day period, utilizing your secure patient portal. You would add up the amount of time over that 7-day period, and that's how you would bill one examination or one code for this patient. So if over the course of 7 days you communicate with them maybe 3 times, and each time you communicate with them it's perhaps 10 minutes, then you're going to have a total of 30 minutes. You're going to bill a 99423 for that 7-day period of time. Next slide, please. So some must-dos for telehealth. These are things that you have to do with each patient that you provide care to. Is number one, you've got to receive a verbal consult from your patient that you're going to be treating them via telehealth, and then you need to document in the exam record that you have the verbal affirmation from your patient that you're going to treat them this way. You need to inform the patient of potential HIPAA privacy risk. Because HIPAA privacy has been relaxed here, it probably won't be followed the way it's supposed to be. You need to let the patient know that there is potential HIPAA issues that could occur from the current telehealth technologies. Once again, I'm going to remind you to use the place of service code 11. Okay, same as an in-office examination, and the 99 modifier. Now, depending on which commercial insurance you're using, some of them may or may not require the 95 modifier, or depending on which exams you're using. I would tell you that anything that is not initially designed for telehealth, like if you're going to use the 99 level office visits that you would use as if you were seeing the patient in your office, I would use the 11 place of service and the 95 modifier. For the other codes, including the telehealth codes, the 994 codes, the 95 modifier may not be necessary because those codes are understood to be telehealth exams, okay? So I can't see where there's a one way to do these exams for every single insurance carrier as far as using the 95 modifier. But what I can tell you, my recommendation is if you're using the 99 office visits, the 99 E&M codes that you use if you were seeing the patient in your office, I would use place of service as 11 and a modifier of 95. And for the other codes we talked about, I would use place of service as 11, but the 95 modifier may or may not be necessary. Next slide, please. So, a couple things to keep in mind that this information on telehealth is potentially going to change over time, and the changes, most of what we talked about today are a direct result of the COVID-19 pandemic crisis, and may change as soon as the pandemic crisis comes to a close. And I don't know that telehealth, as we can perform today, will be the same as we can perform going forward after the COVID-19 pandemic has come to a close. So keep that in mind. Also, it's worth noting that Medicare says that co-pays, co-insurance, and deductibles do apply to telehealth examinations. However, co-insurance and deductible may be waived. It's up to the provider whether or not you want to collect co-insurance amounts and apply it towards the deductible. It's completely up to you. And also keep in mind, commercial carriers, if you go to their websites, you're going to find different rules, different policies for all the different insurance carriers. So unfortunately, there's not a one size fits all here that I can tell you that's going to work for every single commercial insurance carrier. I would give you this advice. If you submit a claim and it doesn't go through, I wouldn't hesitate to submit it again. For one thing, the insurance carriers, they may not be set up for telehealth examinations coming in from all the different providers. And so there may be some initial denials that can be easily corrected just by resubmitting the claim. So don't get discouraged, don't get frustrated. If your claims are denied, I wouldn't hesitate to resubmit them. If that's not working, I wouldn't hesitate to reach out to the insurance carrier and ask them if there's anything specific you need to be doing. And also, I'll be happy to offer my email. You can send your questions to me as well. Next slide, please. So that's basically the new changes to telehealth medicine under the COVID-19 pandemic crisis. And like I said, anything anything could change. So I don't see that anything is necessarily written in stone at this point in time. Happy to take any questions if you have them.
Yes, we have a couple of questions. One of them was about this specifically. Is this verbal patient consent? Oops.
Yes, it is.
Okay. All right, so that one. Here's another one. For 99421 to 423, if Dr. A talks by phone on Tuesday with a patient, then Dr. B talks to them on Wednesday, are 2 visits billed? And
So
kind of
are these 2 doctors from
the same. Yep. If Dr. A
same
talks
practice?
to the patient, yes.
I would suspect that it would all probably go as one. It's a good question. I would say it's gonna probably go as one examination, and I would say that's probably the case for. Yeah, I would say it's probably going to go as one. If you're from the same practice, billing with the same tax ID number, the same group NPI number, I would suspect it's going to go as one if it's being done telehealth. If you were seeing the patient live, then I think you bill 2 different office visits. But since telehealth does allow you to go over a period of time, a 7-day period of time, I would say it's going to be one exam from all practitioners in one location, one practice.
Okay. Just one quick thing. If you are submitting a question and you're submitting it as an anonymous attendee, that's completely fine. However, if you have follow-up questions after, there's no way for us to connect you with Dr. Bots, just as an FYI. So another question is, if using 99202 to 99213, but I am remotely logged in to my EHR, is the POS still 11?
Yes. For the 99 codes, the 992 codes, place of service is 11. Okay, even though you're not in your office doing this, I think it's 11 because I don't think the insurance carrier's software is allowing us to submit the O2, which would be technically the correct way to do it. My understanding is we started out submitting with the O2 as the place of service, and I think claims were getting denied, and I think it's just my opinion, but I think it's because the different insurance carrier software was not set up to accept the 992 codes with the O2 place of service. And so that's why in order to get these claims paid, they're recommending now you use the 11, just as if you saw them in your office. And I think they made that change so that you could get paid in an efficient manner.
Okay. I was under the impression that the virtual check-in codes were reserved for established patients, G2012, G2010, per the CMS fact sheet. Has that changed?
They were prior to the COVID-19 pandemic. And that's one of the changes, is that telehealth does not have to be a established patient. Now that will probably change back to established patient once this COVID-19 crisis is complete. But for now, they do not want patients in your office if it's not necessary. They don't want patients out and about risking infection. And so established or new patient, I think you can bill it for all of these telehealth codes.
Okay. Do you feel this pandemic will allow online exams to flourish, and will we have to make major modifications in the future on our practice habits, or is it too early to tell? The AOA and MOA have tried to quell these online practices.
Yeah, it's a great question. And well, if I had a crystal ball and could look into the future, I'd be able to answer it. But I would tell you, I think since we are, legislated at the state level, I think it will still be different from state to state. I could see where this is going to open up the conversation, and I could see where different entities may try to push this forward. But I think it'll definitely be up to each state to be able to have a voice on what they want telehealth to look like within that state. So I don't think it'll all be the same. I don't think it'll be all 50 states will ever have the exact same telehealth going forward. I think, you know, these are unprecedented times that required unprecedented decisions, and that's why they opened this up. It's all about patient care and being able to take care of patients the best way we can right now during this pandemic. But I don't think that the changes are necessarily all going to stay or remain.
Okay. Those are all the questions that we have submitted. If anyone else wants to type in a question, we can get that answered, or we can finish the webinar. So we'll give just a minute. Just one reminder that you are able to contact Dr. Botts as an MOA member with your billing and coding and insurance consultation service questions. You can find more information about that on our website under optometrists and membership if you have questions about that or what that covers.
Well, with no more questions, I'd like to take the opportunity to thank Dr. Botts for taking time out of his day and for helping to put together this informative presentation for our members. This presentation will be available, and as it's being recorded, it will be available on the MOA website toward the end of the day. So with that, I'd like to thank everybody for attending. And again, if you have further questions, you can direct those to Dr. Botts, as he is one of our business partners here at the MOA to help assist our MOA members. So thank you all for attending, and with that, we can conclude this morning's presentation.
Thank you.